Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Doug. How are you doing today?
I am fantastic, Dennis. How are you?
I'm doing well. Reason why I called you on is I'm going to take advantage of your brain being a cardiothoracic ICU doc. Today, I would really like to do a deep dive on ACLS and probably the easier part of it, VTAC and Pulseless V-Fib. What do you think?
Sounds great.
Perfect. So, I think a common thing being put out, especially on the military side, is we don't do CPR in the field. I don't really think that's always true. Being at least a former battalion doc, what do you think? Is it okay to do CPR even though you're on the other side of a border?
Yeah, I think with a couple of notable situational exceptions, it is reasonable. The first exception obviously is, are you in a safe environment, right? If you are taking fire, and the scene is not safe, it's pretty difficult to mount an effective BLS and ACLS resuscitation when, you're going to have to be moving and going to be interrupted, because as we'll talk about, the hallmark of survivability of cardiac arrest is continuous high quality CPR and ACLS. And I think that's probably the biggest one we talked about, situationally.
Yeah. And the other one we talked about before, like triage, like you are swamped with people who all desperately need your help.
Correct.
We happen to come across a guy who has no more pulse and is not breathing anymore. We would call them passed.
Right.
You probably move on.
Exactly. You're right. In that triage situation, you're not going to have leads on to know, are they in a, resuscitatable rhythm or not. They just don't have a pulse. And, as you're moving through a group of multiple casualties, all you'll have is pulse or no pulse. And if they don't have a pulse, you triage them to black, with good reason.
Yeah. Perfect. So, now, all of my ACLS training, and I have decades of every couple of years ACLS training, they make it look perfect. We have 5 people in a hospital. Everybody knows exactly what they're doing. Everybody's got good communication between them. I never, ever see it happen that way in the military side, outside of a hospital anyway. Being on a team, like there's one dude that knows any real medicine and everybody else is just playing. Like, how is this going to work? Like, how am I going to get this moving forward?
Yeah, I mean, good point. Honestly, all you need in that scene is one person who knows the basics of BLS and ACLS, who can keep a cool head and instruct others, right? And in our discussion before we started rolling, I talked about a recent incident I happened upon in an airport where, a passenger went down in front of check-in, and I was just about to enter the TSA line and saw the commotion and walked over to basically come upon the end of the first round of chest compressions. She had gone down, and, thank goodness there were some bystanders there who knew something. They had checked for a pulse, not found one, started CPR. I came up, introduced myself, and they were more than happy to let me take over. And, started doing chest compressions myself while I, started organizing other people to help, right? So I put one person on timing. I just looked at crowd of bystanders and said, hey, does anybody have a smartphone they could start a countdown timer for 2 minutes? Tell me every time it hits 2 minutes, just to, get the rhythm of the chest compressions and the pulse checks going. And as I was doing CPR, 2 policemen arrived with an AED that they had pulled from the wall. They'd never used it before. I'm sure they'd had, the same type of training you had, every 2 years they had to do it, have their BLS card, but, coach them on how to get the pads out, get the stickers off the pads, put the pads on the patient. And then when we hit 2 minutes, everybody stood back and it analyzed, and she had a shockable rhythm. It delivered 1 shock. I did another round of CPR and we had a pulse. So you just need one person with a knowledge of the steps, and other people who are willing to be taught and participate.
Okay. Well, perfect. Now, BLS, like you mentioned, the foundation for any good ACLS. But at some point, we're going to need to do some extra stuff. Mm-hmm. What other, of the 5 people in all those videos, like what are, I guess, whose role would you fill first or have somebody take over first?
That's a good question. Probably, obviously, cycle through CPR, right? Get 3 people who can, give good CPR, 100 compressions, 100 to 120 compressions a minute, 2 inches of depth, good, which, for our crew, everybody should be strong enough. Everybody's strong enough to do that. That's automatic.
Yep. If you don't hit their spine, you're wrong.
Right. Exactly. Get that going first. Second after that is probably, if you have an AED, get the pads on, or defibrillator, get the pads on so you can start analyzing rhythm. If you don't, then the next most important thing is put somebody on drugs, get the epi out and start getting some doses of epi going. Because, the first several rounds of ACLS are going to be chest compressions, epi, analyze, shock if indicated. And only after you've gone through several cycles of that, maybe 10 or 15 minutes, are you going to start thinking about what other stuff do I need? What other stuff do I need to look for?
Okay.
That makes sense?
It sure does. So, at bare minimum, you need another dude who's strong. Have him go on chest compressions, and you can start working out the other stuff.
Yep. At some point early on, somebody to take over an airway, get a mask and a bag, put 10 centimeters of water, a PEEP on your PEEP valve, and start giving breaths, which you just can be slow and even as you're doing CPR with a mask. Ideally, you want a definitive airway, but it's better to start your mask ventilations in that first 1 to 3 cycles of CPR. So that's kind of it.
So essentially, have another guy take over. You get some kind of access, IV or IO. Mm-hmm. I would guess IO is going to be way easier than getting an IV at this point. You can start knocking out your epi, 1 milligram push. Continue CPR, continue monitoring, and then start thinking about taking over an airway and then have somebody else start bagging, roughly 1 every 3 to 5.
Right. Exactly.
Okay. Perfect. What else? Yeah. So, we're continuing this CPR. We have somebody working the bag. We have somebody that's doing chest compressions. We're trying to think things through. Everybody always says, I'm considering my H's and T's, but nobody ever actually does anything more than consider things. Like, how does this mythical thing of H's and T's, how does this work into your CPR? Because I got a bunch of stuff going through my head.
Yeah, and before we get there, I will say that if you have the luxury of bodies, having a timekeeper is really helpful, right? You'll hit your 2-minute mark for your CPR and your pulse checks, and you will, and that person can be your document. That person can say, your last dose of epi was 3 minutes ago. Do you want more? So keeping track of things, because time will go by, faster than you think, slower than you think if you're doing CPR, because you're like, gosh, it's only been a minute, faster than you think when it comes to like cycling through your epi doses. So the luxury of a timekeeper, and that's, that person can be, completely untrained, right? Your cook can be a timekeeper. Your cook can be a timekeeper and write down,
last intervention,
especially with closed loop communication, epi given, what time, write it down. H's and T's, interesting question. They classically in ACLS enter into the train of thought in PEA and pulseless electronic activity, where it's not VT, it's not VF, they don't have a pulse, but you've got some rhythm on the monitor. But they're important for, I think, all types of rhythms, because they get at, what could we be missing that if we correct it, could improve our outcome, our ability to restore spontaneous circulation. And so, with VT, VF, which is the focus of this podcast, I would get to the H's and T's after several rounds, like, 5 rounds or so at the 10-minute mark. And I keep seeing a shockable rhythm. I keep delivering shocks and they're not getting in. I've got the right dose of epi. I've got access. I know what's going in and they're not responding. And so then, the big ones that you think about in our environment are going to be hypovolemia, right? Is this a traumatic scene? And, their blood volume could be so down that even with good circulation, there's just not enough blood in the tank to perfuse the heart. And do I need to get, some blood going? Acidosis is a big one. Is their pH so low that they're not responding to the epi? pH of less than 7.2, 7.1 for sure, they're not responding to the epi. And you don't necessarily need to have an iStat and run the lab. You just be like, hey, we've been at this for 10 minutes. They're not coming around. Let's try some bicarb. We're not going to hurt them. And it might help. 1 amp or 2 amps. I generally, in an emergency situation, would do more rather than less. I almost never give 1 amp. I'm always like, let's give 2, right? If I've got them, let's give 2. Because you want to kind of front load your auxiliary actions to be as effective as possible, as quickly as possible. Hypoxia is a big one. Get a pulse ox on their finger and, is their pulse ox 70? Well, what can we do about that? Can we give more effective mask ventilation? Do we need to switch to like 2 ventilators, one for a mask seal, to get a better mask seal? Or do we need a definitive airway? Probably not off the bat. Are you going to be like, let's put a tube in. But if you've been going for 10 minutes, 15 minutes, you're not successful and the patient's pulse ox is 70, 80, and despite like a good mask seal and good rise and fall of the chest when you're giving this ventilations, you might want to think about that. That's going to be tough to do. Getting an airway in is tough to begin with. Getting an airway in while CPR is ongoing is tough. I mean, we do it, but, it's usually anesthesia and they're pretty good. And then probably the last thing is, some sort of tension physiology, right? Do you have a tension pneumothorax that is impeding the ability of the heart to expand and fill with blood and perfuse itself? Signs of that would be, I'm masking this patient. It seems like it's really hard to squeeze the bag. That's an indicator that you have, potentially increased intrathoracic pressure. And you can listen, obviously. That's a pretty effective, way to assess for, lack of air movement on one side, needle that side. You can throw an ultrasound probe on, look for sliding lung sign or the seashore sign on both sides. And as you get deeper into the resuscitation, at some point, if that's what you suspect, putting in a needle D is you're not going to make the person any sicker than they are. It might be something just to try. I have needle D'd people, 15, 20 minutes into a resuscitation, empirically. Unfortunately, it didn't help in that situation, and it might not have been what's going on, but at least we got it off the table.
Right. I think once you're getting, maybe five to 10 rounds in, if you're not thinking or talking to somebody that saw this happen, you're probably in the wrong, and you're probably in over your head, I would imagine. Like, did anybody see this happen? Like, what happened? Try to get some kind of history of whatever you possibly can.
Right.
Do whatever assessments you can in the midst of all this chaos. Like you mentioned, maybe you can't do a complete fast exam, but you probably can at least look at one side, if not the other. Do you see the lung slide? Are they obviously, they're laying in a pool of blood? You can probably guess what the problem is.
Right.
So things like that to at least clue you in on what happened, and that can lead you into what you need to do to try to fix it.
Yeah, exactly.
Okay. All right. Very good. So, we've considered our H's and T's. We've done the things, like you mentioned, earlier, just dropping a needle, like the guy is already dead. Like he's not going to be mad at you now. You put a needle in his chest. Do something to try and fix the situation. But let's say we've been successful and we've got some kind of pulse. I would imagine it's not going to be perfect, and I don't imagine this guy's going to wake up and say, "Thanks, doc." I would imagine it's super tempting to start high-fiving that we saved this person's life. But just like after an attack, be ready for the counterattack. What do we need to do to make sure that this guy doesn't just slip right back into it?
Yeah, great point. And it's actually one of the most, risky periods in an ACLS resuscitation is what you do in those seconds to minutes after you get circulation back. Because you're right, the temptation is we got him back, but you really need to jump into how the hell do we keep this from happening again? Because the heart is still really unstable, right? It doesn't know what hit it, right? It's had people pounding on it. It's had electricity running through it. It's barely gotten perfusion back. The risk of it slipping back is super high. And the other thing is there, an obvious cause that we need to look for aggressively and intervene on if we can, like, hemorrhage. Is there something we can stop? And if not, how's our resuscitation? Do we need to give more?
Perfect. Or, that airway that suddenly got his SpO2 up, which was able to bring him back. Well, if he wakes up at all, he might pull that out. So some kind of post-ROSC sedation, I would imagine, which you had better be really careful with, to make sure that the airway stays in place.
Yeah, and if you don't have an airway in, if you've been lucky enough to get circulation back with mass ventilations, now's the time to get one in. It's pretty rare that people wake up and follow commands. It's after more than a couple of rounds of CPR. If it's more than that, if it's 10 minutes plus, the brain will have taken enough of a hypoxic hit that they're going to have some hypoxic brain injury, which very well can be temporary, and by temporary, I mean like hours to a day. But, now's the time to secure the airway. Get the best neurologic exam you can, but don't hang around waiting for them to wake up. Because at that point, the best thing you can do for the brain is keep them calm. Don't increase cerebral oxygen demand, which is only going to worsen a hypoxic brain injury. You kind of now have two patients. You have an arrest patient and you have a TBI patient, a severe TBI patient. So everything that we do for severe TBI, keep them calm, keep them oxygenated, don't let them get febrile. You want to add that into your algorithm for post-arrest care.
Okay. Something I'd missed before, other than epi, we have our antidysrhythmics. You have amiodarone, you have lidocaine.
Mm-hmm.
Amiodarone I haven't really seen lots of. I'm sure it's there. I'm just not that smart. But I have seen lidocaine like everywhere.
Right.
Is there a benefit to one over the other, or just pick your poison?
No, for VT and VF, they're both equally indicated. And you sort of, if resources are limited, you use the one you have. We tend to have amiodarone and use it a lot because it's good for a lot of unstable dysrhythmias. It's good for SVT. It's good for, about the only thing it's not good for is bradycardic arrest, but we're not going to go there because it does slow the heart rate. It's a nodal blocker. But yeah, lidocaine, 1 milligram per kilogram, typically give 1 milligram, usually during the code, and then afterward you can give 1 milligram, and then you could start an infusion at 1 to 2 milligrams per hour, or 1 to 2 milligrams per kilogram per hour. Honestly, people are close enough to 100 kilos that with that dosing range, if you just start 1 milligram an hour, you're probably going to be fine.
Okay. And calcium, is there any kind of titration that goes with that, or you just set it and go?
Set it and go. And the same with amiodarone. Amiodarone is typically 150 milligrams as a bolus. And then it's also, I'm trying to remember the milligrams per kilogram. But if you do 1 milligram of amiodarone an hour, you're probably going to be good enough.
Yeah. Yeah, that first dose of amiodarone, 300 milligrams, and then the subsequent is 150.
Right.
But then you get into a drip. Yeah.
Yeah. And that's your arrest dose. Your post-arrest care dose as an antiarrhythmic is just 150. That's what we would use for AFib. But you're right. During the code, if you have 300, you would get that.
So that's all the happy stuff. ROSC happens.
Mm-hmm.
Let's talk about the unhappy stuff. This guy is not coming back. I've racked my brain with H's and T's. We've sent bicarb. We've stuck him with needles. We've done the things. At what point do you call it?
Great question. And as we were talking about before we started recording, there was a paper out recently that sort of talked about that question in the hospital. The important thing here, and something I meant to mention earlier, is there's a huge difference between a witnessed cardiac arrest and an unwitnessed. I saw the guy go down. I went, felt for a pulse, didn't have a pulse. I started CPR, or I got help, somebody who can, and we started CPR right away. Versus I found this guy, down and pulseless, and nobody knows the last time he or she was seen. Outcomes are far better for witnessed cardiac arrest than they are for unwitnessed. So people do come back from unwitnessed cardiac arrest, but not nearly as many, and not nearly as successful a neurologic recovery. So the gist of the paper was we probably should think about going longer than we do. I think by longer, if I recall correctly, they were talking about, 30 minutes plus, because, and especially with young, healthy people, I think longer is worth a shot, because they have more reserve. The people where we tend to do shorter codes in the hospital are, older, lots of comorbidities, they've had several heart attacks. They, have uncontrolled diabetes. They have known heart failure. In those situations, people in the hospital aren't wrong to call a code after, 20 minutes or so. But I think, probably 30 minutes and, as long as an hour. That's a long time though. So at some point you have to, look at your team and be like, we're so tired that we can't give effective chest compressions anymore. We'll have to call it for that. The notable exception that we talked about also before we started recording was hypothermia, right? Somebody who's really, really cold, 28, 30 C, give them a good shot at warming up before you call it. But people warm slowly, and you may not have the resources to do that.
Right. Absolutely. I think definitely the temptation, like if I know our guys well enough, we will go until our arms fall off. There is no epinephrine in country. We have utilized absolutely every resource possible, and we'll only stop until somebody makes us stop. So I don't think the idea is to give us the excuse to keep going. It's when is it realistic? Like, even if we did bring him back, Steve is not going to be Steve anymore. Right.
And, in a big trauma, I remember a story that, our friend Sean from the Prolonged Field Care Working Group told me once of, having a team out in the field doing ACLS for a trauma victim. And I think they had been going for an hour when he called him, and he's like, guys, this guy's not coming back. You've done everything. He has an unsurvivable, traumatic arrest, probably hypoxia from severe hypovolemia. And, unless you had a surgeon who could get in there and tie off whatever is hemorrhaging, he's not coming back. Telemedicine is not a bad thing to invoke, during a cardiac arrest, if you have a bandwidth. I think it would be a great thing to invoke. And Sean's story is instructive that, you're right, that team probably would have kept going. We might still be there. And this was years ago. Because if it is one of your teammates, of course, it's going to be hard for you to say, let's stop. And you need somebody outside who's objective to say, hey, you've done everything you can. He has an unsurvivable injury, or an unsurvivable cardiac process. You have to stop.
Yeah. And I think it's one of those things like in training, super easy. Like, oh, we've been doing this for like 3 whole minutes. Like, all right, like we're deployed. Like we shouldn't have even started. We're calling it. But when it's your teammate, it's your loved one, it's, fill in the blank. Like you're not thinking straight. Like, right. You can think medical. You can think this is the algorithm. We're doing the algorithm. We're doing the battle drill. But to stop is like a mountain that I don't think a person with a soul is willing to cross.
Yeah, that's the hardest time I ever had, and I'm generally the team leader in all the codes that I respond to, and certainly all the ones that happen in the ICU when I'm in service. The hardest one I ever had to tell the team to stop was an 18-year-old who was one of our patients, who arrested, and that's as close as it, even though he's not my kid, that was a hard one. It was a hard one for the team to stop, and it was a hard one for me to say, we've done everything we can, but we had, and the right thing to do for him, and for his family and for the team was to, put the emotions aside as much as possible and make the decision.
And I think just doing the CPR, just doing the ACLS, doing the interventions, if the family, I don't know if they're able to see that happen, but and I'm just thinking of not necessarily the family that in the story you're talking about, but I'm thinking of the teammates who are absolutely going to be there. They get to see that like everything was done. Like,
right.
It's mentally easier.
Right. And there is actually literature out there that talks about, because it used to be, we started CPR on a hospital patient, we shooed the family out of the room. That still may happen, but we bring them back pretty quickly. And if they're not there, sometimes they come in, right? We call them and say, hey, your loved one's arrested, and we're, the team's working on them, and they're close. We bring them straight to the bedside because there's more closure. As terrible as an event as it is, there's more closure for the family to have witnessed everything being done than not. Than to, be sitting in the waiting room and have the doctor walk out and say, we did everything we could. There's more doubt with that, that can lead to, long-term mental health consequences for the family and doubt, etc., than if they're there. And so we'll always bring, if we can, we'll always bring family there, and maybe, with a teammate that's leadership, maybe it's the rest of the team if they're not already there, to see it. It's a terrible situation. But we're just we're talking about how to enable medical leaders, medics, PAs, physicians in that situation, in that terrible situation, to do the most they can to optimize it and hopefully get a successful outcome. And if not, to do the best for all the teammates and team.
Yeah, absolutely. I mean, it's not 100% success in a hospital in the West.
Mm-hmm.
It's even less when you're talking an austere, rural, regardless of the provider that happens to be standing nearby. So it's going to be a difficult thing. And I think just knowing at least some basic, guidelines of like, hey, at this point, we're running out of resources. We're running out of people. Like, it's going to be close to time to call it. Maybe we need to bring the rest of the team in and eventually call it. Right.
Exactly.
Yeah. Cool. Anything else that I missed out as far as ACLS and VTAC and Pulseless V-Fib?
I don't think so. To the point of telemedicine, in terms of decision making about whether to continue or not, telemedicine definitely has a role in your post-arrest care. Both in terms of advice and guidance and dosages for stabilizing the patient, and also for, advice and guidance on looking for a cause and potentially treating a reversible cause. Heart attacks do happen. Heart attacks happen in the young. I've had, obviously, we had a young man recently who had a cardiac arrest, in West Virginia, and was saved by bystander CPR. And, you wouldn't think that, a young college student would have a heart attack, but he did. And fortunately, 3 brave young classmates witnessed it, started CPR. EMS arrived, shocked him back to rhythm, and he survived. So heart attacks happen at any age. And I would say if that's where you're left on your differential and you're in an austere environment, let your medevac team that's arriving know, because they may have some things that can help, stabilize somebody with a heart attack. They may have thrombolytic drugs that can open up blocked arteries. They may have more antiarrhythmics. They may have a heparin drip that they can put them on until they can get them back to a roll 3. So don't assume that your rescuers are going to bring everything that the patient needs. They should, but close the loop and say, hey, this is what we're left with. Here's a ZKG, review it. If it really looks like ST elevations or ST depressions, signs on the EKG, signs of a coronary artery blockage, bring some things to help deal with that. So take a picture of their heart function and send it to them, on your ultrasound. Have somebody take a video on their cell phone and send a video of what the heart looks like. That can all be super useful. Those are sort of my parting thoughts.
Well, thank you, Doug. I really appreciate you jumping on.
You're welcome. Thanks for having me. Sorry, it's a tough topic, but as we said in answer to your opening question, there are very few situations where it's not worth at least a shot. Hopefully this provided some information to help people who might be in that unfortunate situation give it the best shot possible.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.